Oh, hey, Chris.
Hey Chuck, how are you?
Great. We have a special guest. That's why I'm great.
Well, I'm sure there are many reasons to be great, but we do have a special guest. We're happy to welcome back Macy Stonner.
Hello, everybody.
Macy is
Hello.
our therapist extraordinaire that everybody keeps asking for, and she's here to provide some interesting perspectives. So we're excited to have you back, Mace.
Thanks. It's always fun to be here.
She's also an award-winning therapist. We shouldn't let that slide.
Yeah, I think they asked for both you and I and one of our colleagues, Mitch Pett, to provide some insight as to why Macy was voted the Researcher of the Year for WashU Occupational Therapy.
Well, thank you very much. Yeah, I was very honored. It was actually called Director's Choice Award or something, just to kind of honor those who do research, program development, clinical stuff, kind of a jack of all trades but master of none type thing, where you kind of excel in small areas and nothing huge in one. So yeah, I was very honored.
You're being way too humble. I think it's very, very challenging to do research as a clinician in general, but especially I think in the therapy specialties, just because there is even less protected time, if any protected time, typically for research, and less resources. So your ability to not only to serve as an investigator, but also to be a collaborator has been remarkable, and I've always really appreciated that. You do incredible work.
Oh, y'all are very sweet, and I have great mentors. So thank you for that.
Yeah, definitely. And I appreciated participating in one of your studies looking at tendon outcomes, which is just a super challenging area to research. And I think your contribution there was an important one, and I look forward to your building on that.
Thank you very much. We're not talking about tendon outcomes today, are we?
We are definitely not.
But
Definitely
Chuck,
not.
you a few weeks back, you sent out a really cool email to our to those that are on our listserv. So if you're not on the listserv and you want to be on the listserv, you can find information in the show notes, but then also email us at handpodcast@gmail.com, and we'll make sure to get you on there. But you did ask for some feedback and some questions. What'd you hear back on the survey, Chuck?
Responses are still coming in, and to be honest, I feel like we are multidimensional in our approach. Every time I log on to this question with this tool, I always forget how to do it because let's be honest, we do not want to overwhelm the listeners with another piece of email. So these are quite infrequent, 2 or 3 times a year. And so maybe we'll save the responses for the next episode or two. So I'm excited. Read the email. Please send us your thoughts so that we can make the Upper Hand podcast even better.
What a tease. What a tease, Chuck. And hey, if there's anybody out there that wants to be a social media intern for our podcast, please let us know. I can't say that we can commit any resources to you aside from fantastic mentorship and a great experience, but we are in sore need of finding folks who would love to help with that. So yeah, let us know.
I did get a great email from a friend and former fellow, Kevin Lutsky. Kevin was in Philadelphia for many years. And he, I guess I was going to say recently, has spent a couple of years relocated to the University of Vermont. And it's just so interesting to me, not that I have overly grandiose expectations for the impact of our podcast, but we were emailing about a case and he said, by the way, one of our residents just told me about the podcast. I had no idea. I love it. I'm hooked. And first of all, thank you, Kevin. And Kevin does great work with the Hand Society as well. But it's awesome when someone discovers it and they like it. So very cool. Very cool.
Yeah, we don't want to hear about it if you discover it and you don't like it. So just keep that to yourself. But Kevin heads up the effort for the Hand Society to do the Perspectives newsletter, which is really cool because it's kind of like this podcast. People talk about their experience with being a hand surgeon, not necessarily just about hand surgery itself, but about life. So if you haven't checked that out, make sure you check that out.
Yeah, and maybe I'll share one more comment, and then if we have time, let's do a quick listener submitted question, which will be for you, Chris, and then we'll jump into Macy and her expertise. Does that sound okay?
That sounds great.
So we had a comment again on one of our mini streams from Laurie, who was commenting about Megan Conte Mika's guest appearance for our distal radius malunion pod, and she said, "Excellent discussion, practical, informative, and I will be incorporating this knowledge into my practice." That's a win.
Absolutely. Whenever anybody can find something that they can use. Honestly, in that conversation, I learned from you and I learned from Megan, so I thought it was fun too. So thank you, Lori, for that feedback and for listening.
Yeah, Macy, no pressure today. You gotta up the game and make sure people write in stuff like that about your therapy pearls of wisdom.
All right. Challenge accepted.
All right, before we get there, Chris, I have a question for you. Which actually I think is a very fair question that I must admit I could use some clarification on as well. What is the difference? This is from Anonymous. What is the difference between TMR and RPNI? I have heard of TMR and worked with a patient that has had this, but I'm not familiar with RPNI. Dr. D, enlighten us.
Okay, so I'm trying to figure out how to keep this really brief without losing Chuck and then eventually losing Macy. But so TMR is targeted muscle reinnervation. RPNI is a regenerative peripheral nerve interface. Now, those are two techniques that are typically used for neuroma treatment, but TMR has the additional advantage of being able to be used in a setting potentially of helping somebody who's going to get a myoelectric prosthesis, particularly one that picks up signals from surface electrodes. The idea here is that for TMR, you're taking usually a major peripheral nerve or an important sensory nerve, but usually a major peripheral nerve. And sometimes it's in a setting of an amputation, or other times you're doing it intentionally to treat pain, but you're trying to give that nerve something to grow into. So with TMR, you are denervating a muscle by dividing the branch that goes to that muscle. And that's intentional because you already have a major nerve that you're trying to get to reinnervate into something. You're trying to give it a hence targeted muscle reinnervation. The impetus of this initially was to treat the amputee, but in the studies that were performed and largely led by folks at Walter Reed and then University of Washington as well, they found that actually helped a lot with neuroma-related pain after amputations. The thought being is that you've actually given that major peripheral nerve something to do rather than allowing it to be a potential pain generator. So that's been a really useful neuroma treatment. RPNI is a different way to treat a neuroma, and that's, again, a regenerative peripheral nerve interface, where you're essentially taking a piece or a cuff of muscle, and it's almost you're completely really dividing it out, and you're making it a free piece of muscle. And by denervating that muscle, now that muscle is receptive to receiving reinnervation, and then you're taking a cut nerve end and you're putting it into that cuff of denervated free muscle and allowing it to grow back into that, again, giving that nerve something to do, with the thought being that if you're implanting a nerve into denervated muscle, it will then try to reinnervate said muscle. That's what it is.
So yeah, a couple questions. Number one, can anyone do these procedures? Is this a hand surgeon, nerve surgeon only procedure? Do our orthopedic trauma colleagues do this? Do tumor surgeons do this? Who does this operation?
Honestly, anybody could do it if you really wanted to. I think, like anything, it does tend to come down to indications. There can be some technical things that are tricky with like size mismatch for TMR, but can be overcome. For example, one of our fantastic orthopedic oncology partners, Ian English, I think has actually done TMR and RPNI on his own when he's doing some of these big oncology resections, or at the very least has learned enough from, usually he's collaborating with David Brogan, and he's learned enough from David and from his past experience, and he's come up to me saying, what do you think about doing TMR or RPNI in this particular patient? So I think if you want to do it, you can. And the idea behind doing especially something like RPNI is that you can take these surgeries and take them out of the hands of the nerve surgeon, because you can't have a nerve surgeon there for all of these cases. And perhaps you could avoid having to go back for a second surgery. So I think anybody could do it. It doesn't have to be a peripheral nerve surgeon. It doesn't necessarily have to be a hand surgeon. It just happens that those are the two populations that tend to hear about these things more.
One more question for you, then I have one for Macy. Do you have a preference over those two techniques, or do you use both techniques in different situations?
I think you got to know how to do all the neuroma surgeries. One of the comments that I think that was made at this past year's ASPN meeting is that we're not going to have an algorithm that says, always do RPNI or always do TMR. It's going to potentially be, this nerve in this situation responds better to RPNI, or this responds better to TMR. Sometimes you're at a level anatomically where you actually don't have any good targets for TMR. Sometimes you're at a level anatomically where you have some great targets for TMR. It's a complete freebie. So I think it's important to know how to do RPNI, TMR, potentially intraosseous or intramuscular transposition of a neuroma end, all the different things, just so that when you're in a jam, you can figure out how to best serve that patient that particular moment.
Perfect. Macy, I know you're not really involved with lower extremity amputations, or at least not very commonly, but what's your experience been in seeing these patients after either of these neuroma type surgeries?
Sure. So I feel like the ones that have been performed for neuroma pain, we don't see a whole bunch of. I have found that working with them for many weeks or months on desensitization and graded motor imagery and things like that, and then they end up going to get the surgery and they're like, oh my God, I'm so much better. So it kind of de-emphasizes a role for us, which is great because they do so well. But in terms of prosthetic training, we see them quite a bit. Again, I don't see the lower extremities. I refer out for those, but the upper extremity ones, I've seen quite a few. And there's a big role for just like the cognitive component of understanding the new roles of the muscles in their arm and their residual limb. So like learning how to fire each one and learning not to co-contract, a lot of mirror type exercises. But it's particularly important for the prosthetist to join those sessions as well. It's a big collaborative approach, and it's really enjoyable to kind of see everything fall into place, especially when they get their EMG machines and kind of visually have biofeedback to look and understand how to activate their new motor pathway in a sense.
Sounds like an episode to me.
Yeah, it absolutely is. I mean, there's some fascinating work being done. The videos of watching somebody, figure out how to use a prosthesis after having TMR is pretty incredible. And the idea for at least in the setting of a prosthesis is to get those signals closer to the skin where they can be picked up, by the prosthesis. So yes, be a fantastic episode, completely nerdy, and we might lose you within the first few minutes, Chuck. But what's your perspective on these things as a relative outsider to, have you ever thought of using these in any of your patients, or is this something where you're just kind of still learning about it?
I would say I'm still learning about it. It doesn't have direct relevance to my practice frequently. Certainly the concept of implanting a nerve into muscle, and I would just say it like that, is part of what I do if I'm treating a neuroma or trying to prevent a neuroma. But I have to say the explanation was actually helpful for me, and I think I need to continue to process this as I look for indications in my patients, because let's face it, I take trauma call, and so I see the injured worker particularly, and this is relevant, highly relevant.
Yeah, I mean, I think that the classic papers that describe neuro treatment from back in the 70s and 80s, when Lee Dellon and Susan McKinnon were initially describing this, transposing nerve into bone, for example, and transposing nerve into muscle. What's different here about TMR, obviously about RPNI compared to dunking the end of the SRN into the brachioradialis muscle belly, is that that muscle belly that you're dunking it into in that setting without RPNI is actually still innervated. So the thought is maybe it's not actually growing into that muscle because that muscle is not theoretically receptive because it's already got innervation. So you really are just potentially giving that nerve a road to nowhere. Whereas in RPNI, you're trying to give that nerve something to do. And I think it's a philosophical difference, and maybe it's academic, but I think it is important to know how to kind of do all these things, before we, because we're still trying to figure out what works.
Right. At the risk of this becoming a nerve episode, I'm taking co-host prerogative. And I'd like to thank our sponsors before we shift to Macy.
Yeah, so staying with the nerve theme, let's talk about one of our sponsors. The Upper Hand is sponsored by Checkpoint Surgical, a provider of innovative solutions for peripheral nerve surgery. The company invites you to visit them at booth number 605 at the ASSH annual meeting in Toronto to learn about their new products, as well as attend their industry forum on Thursday, October 5th at 11:30 a.m.
The program, Nerve Injury Reconstruction Challenges, will be moderated by Dr. Scott Cozen, Chief of Staff of Shriners Hospital for Children in Philadelphia and past president of the ASSH. To learn more about this program and to register to attend, please visit nervemaster.com. Checkpoint Surgical, driving innovation in nerve surgery. Let's go. I'm already
Yeah, yeah.
excited.
You know that guy, Scott Cozen. You've been around him before.
He's masquerading as a nerve surgeon. He's a congenital hand surgeon. Don't let him fool you.
Well, you know, the ceiling for being a congenital nerve surgeon is much lower, or congenital surgeon is much lower than being a nerve surgeon, right?
For sure it is. All right, Macy. 57-year-old, delightful female patient of mine has had 3 injections for thumb CMC arthritis. She's right hand dominant. She does not have any structural abnormalities, does not have any contractures. She's tired of the injections despite initial good results, and so she has requested surgery. We discussed the options with her surgically. We discussed classic LRTI. We discussed new suspension plasty techniques, and I would love to know how you think about her care for a typical LRTI. So just so the listener understands what I mean by LRTI, this is a procedure that was described 50 years ago, and essentially it includes a complete trapeziectomy. I harvest the entire FCR tendon, pass it from its insertion on the base, volar base of the second metacarpal through the thumb metacarpal, and then I create sort of an anchovy or ball and pack it in the deficit where the trapezium was excised. So I have seen this patient, I've operated on this patient, I've immobilized her for 4 weeks, and we can talk about that. And she shows up in your office. Make me look good, Macy. Tell me what you're going to do for this woman.
Okay. So before I even ask this person to move her thumb, I'm just going to look at her thumb and I want to document how she's resting. So has she resumed a, quote, what I call collapsed posture? Is her CMC joint kind of flexed? Is her MCP joint extended to hyperextended? Does she look like she's adducted and kind of tight into the palm? Or does she look rock solid? Does she have her CMC joint kind of resting in a little bit of extension with her with her MP joint flexed? So I just want to look at her resting position because that's going to tell me a whole lot of, I guess, how I want to fabricate her orthosis, how long she's going to be immobilized, and the frequency and type of exercises that I will provide her. So let's say she looks a little bit loose, like she's a little bit not recurring, like a Z deformity, but just not quite tight enough. I'm probably going to be really nitpicky about her splint and really kind of support that CMC joint into a little bit of extension and palmar abduction, keep her MP joint flexed. And I'll probably want her to stay immobilized for another 2 weeks. Don't hate me. Just because sometimes I'm not one to get them moving too quickly. Like, what's the point? It's a pain procedure. I want to make sure that they stay pain-free, especially in this particular case. If she looks a little bit loose at the CMC joint, she just might have had a lot of laxity preoperatively, and who knows, might have just been a tougher case. So I would probably, Dr. Goldfarb looks like he wants to say something. Sorry.
No, I don't want to interrupt you.
Oh, okay.
Oh, he did. He wanted to.
Okay, can I keep going?
Please.
Okay. So I would bring her back, depending on how swollen she is, within a week or 2, just to kind of monitor position. Because the worst is if they're really swollen, they lose swelling, and then their splint doesn't fit as great, and they look like they're kind of subluxing a little bit or just not quite as supported. So I'll monitor that. And then at 6 weeks, start some exercises. What exercises? Gosh, there's so many you could do, but I just want to make sure that she can.
Well, I'm going to stop you first.
Yeah, sorry. I can go on and on. So
yeah, you were blanking out. You were blacking out like an old school.
I was just like going.
So does your, Chuck mentioned doing an LRTI for this patient. Does that initial assessment, which I think was incredibly thoughtfully stated, does that change whether based on the type of suspension plasty type procedure they had, whether that was with a thick suture tape or whether that's with other tendons, or is that just for LRTIs with an FCR suspension?
No, that assessment is for anybody that has a CMC arthritis reconstruction. But I'm going to be a little bit more conservative with the LRTI folks and like an internal brace, for example. But even if somebody comes out with an internal brace, it says at 5 to 7 days, get moving. I'm very fortunate to have quite a bit of autonomy in our clinic, and I'm going to look at that thumb. And if I don't really feel like they're stable or pain-free enough, I'll still email the surgeon and make sure it's okay, but have them probably continue to be a little bit more mobilized for a while.
2 questions. So the first,
of course.
Macy, of course, 2 questions. The first is, we as surgeons like simplistic protocols. And so one of the critiques of the LRTI is the length of immobilization. And classically, it was 6 weeks. And then some people, Doug Hutchinson has talked about 4 weeks. And could it go down to 2 weeks? And what I'm hearing you say is maybe the initial immobilization needs to be, particularly addressed for each patient. And so maybe we as the surgeon need to do what you as the therapist are doing in the clinic and say, okay, I've just done my reconstruction. I've got nice extension of the CMC joint. I feel comfortable with the posture. Maybe this one's a 2-weeker, whereas someone else is a 6-weeker. So that's my first question. Don't answer that. And the second question is regarding LRTIs. Have you seen bad results when you mobilize an LRTI too fast? I mean, they're interrelated questions, but we talk about prolonged immobilization for LRTI and quick mobilization for suspensionplasty. Have you seen problems in either direction?
I'm trying to understand your question. Hang on. So I think you're asking, do you see problems with too much immobilization? Is that correct?
I guess I'm really asking, to make it really simple, because you and I are both from Alabama, and you got to make things simple for people from Alabama. Do we need to immobilize LRTIs longer? Have you seen problems when we've mobilized LRTIs too fast?
I think no more than 6 weeks. I think 6 weeks is great, because coming from the outcome that I don't want to see is recurrent pain. That's the outcome that I would see normally, as opposed to the outcome being stiffness. Like, I rarely see somebody long-term as having a lot of chronic stiffness from prolonged immobilization. So I'd rather see a 6-weeker, splint versus cast. I think that's great. That's a lot of time to be immobilized for the patient's sake, but regardless, from an outcomes perspective, I think that's fine. There have been some cases where I see 4-weekers do just fine, pending their posture is good, they're pain-free, they look stable, and they don't resume, repetitive pinching and activity too early. So between 4 and 6 in my world is excellent. The problems that I see is when the orders are for a hand-based thumb spica, because I feel like they often get some wrist discomfort. So I feel pretty strongly about including the wrist there for an LRTI. You mentioned something about 2 weeks, and that seems mean. I think that people would be particularly painful for an LRTI.
And that's 2 weeks after the initial, 7 to 10 days after surgery, or is that?
No, that's 2 weeks post-op.
2 weeks post-op. Now, you mentioned the wrist discomfort after an LRTI if you leave the wrist free. Do you think that's from the, crossing the wrist with the FCR that you've harvested, or do you think that's just because, the nature of having a surgery at the thumb base and having some swelling? Like, if you did anything other than an FCR suspension, so something that doesn't cross the wrist, could you leave the wrist free?
I think so, because that's my assessment as well. It's got to be that, because for the internal brace folks, we always do a hand-based, and wrist pain is rarely a problem. And so my only hypothesis of that would be because of the FCR tendon involvement.
So I have 2 questions to ask, but unlike Chuck, I'm going to ask them one at a time so as to not confuse the one who is answering the questions with.
Thank you. I'm like, wait, which one?
Complexities. And I'm going to ask Chuck's question.
She's not simple.
I'm going to ask Chuck's question a different way, because I actually really want to know the answer. So, to go outside of thumb CMC for a second, with my straightforward distal radiuses, we have kind of a faster protocol.
Yes.
What Jamie and I will call a brick tops protocol. But then for like the for somebody with the more complex fracture, we will go slower. Now,
what do you call that?
The normal protocol,
Okay.
The slow protocol. So I think that I think that you're saying that you can tell based on somebody's initial posture of their thumb after surgery that they're either they're pretty solid or they're collapsing back. Now, can we just have a fast and a slow protocol for these based on that initial assessment, regardless of the type of surgery that we do?
Sure. If you're looking to make it more black and white, then I think that's fair. But just to go back, it's not it's not 100% about just the way they look. I'll ask them, how are you? If they're like, I feel great. If they're like, oh, my pain's a 10. Okay. And then I might have them touch each finger and kind of see what their thumb's doing. But most of it is observation and kind of looking at how they're posturing.
So I think that ultimately, my second question is that, there's, we talk about this, the outcome of this, you're describing as more of a, let's make sure they remain pain-free surgery.
That's what I care about. Yeah.
Yeah. And I think that's absolutely fair. I mean, that's what this is for. The thing that tends to hang up patients, at least when I counsel them about surgery, is, how long will it be until you're using your thumb without thinking about it? Because I remember listening to one of our current partners, Ryan Calfee, counseling patients about it. He's like, it's going to be about 6 months until you use your thumb without thinking about me. Is that an accurate assessment? Because we did some qualitative work with one of our former fellows, Jeff Steppen, who actually interviewed a lot of my LRTI patients, and I was definitely underappreciating how long it took for patients to get back to functional recovery. So is there anything we can do that would move up that functional, pain-free function, earlier?
I guess encouraging them to go slow. And the quote I use is, let's do this right the first time. Let's just be conservative in the beginning, and it's going to have better outcomes for you long term. I normally say 4 to 6 months to use your hand normally, but again, they might have full range of motion with a 0 out of 10 pain with just gentle activities by 8 weeks. That doesn't mean that they can go writing and using a hammer and be pain-free. But I'm babbling now, but I think the biggest thing is just to do it right the first time. The first 6 to 8 weeks, just adhere to your precautions, be gentle, don't go too hard, too fast, and make sure to be compliant with your splint.
So really, it's really interesting because we are maybe internally rather than externally motivated to try to get patients moving ASAP, right? That seems to be the goal. Shorten the period of immobilization because that's better. And I've always sort of hesitated on whether or not that's true. And it seems like 4 to 6 weeks of immobilization after a surgery like this, while inconvenient, it shouldn't be sold to a patient as a negative. And I'm guilty. As I talk about the benefits of suture tape suspension plasty, I say, well, you can get out of the, you can get out of a cast at 5 days, and that's wonderful. Maybe it is. And certain people, maybe it's a priority, but it does seem like this shouldn't be about rushing you through recovery necessarily, because hopefully this patient has a lot of, functional pain-free years when treated in the right hands post-operatively.
Mm-hmm. And I'm particularly biased because at our center on Tuesdays, I'm on walk-ins, which to listeners just means that I come in to work with a blank schedule. And as physician clinics that are running will send patients who need same-day services. And Dr. Martin Boyer works on Tuesdays. And so I see so many of his patients, and he has a lot that have had from outside institutions or just second opinions, and he sees them that have had 2 or 3 different CMC procedures. And so a lot of times we're a little bit more conservative with those because of their history. So again, I'm recognizing my biases in these cases.
Wow, that sounds like a clinic I wouldn't want to. Before we move on to our next question, I did want to shout out one of our sponsors. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/theupperhand. All right, I like this conversation. We should keep going a little bit more.
I have one question. I'm going to jump in.
Okay, jump.
I want to know about this wrist pain thing, because that's not something I typically have thought about. And now you said it's because, perhaps harvesting the FCR, there are a lot of other procedures that use tendons that cross the wrist, like a Wiley type suspension. Jeannie Del Signore's suspension uses tendons that cross the wrist and doesn't, harvest them, but does change their course a bit. Have you noticed? Because I think you see patients, perhaps, or your colleagues do from the other surgeons at our institutions that use some of these different techniques. Have you noticed wrist pain is an issue for those patients too?
I don't get too bogged down with the incredible details of the surgery like surgeons do, but what I do notice is whenever they get out of their post-op dressing, that includes the forearm all the time, and they go straight to a hand-based, whatever procedure that is, well, with a tendon reconstruction, like an LRTI. That's when I noticed the issue. So internal brace, like I mentioned before, typically not. Did that answer your question? Like it's all about the length of time. So if somebody goes from a cast, at 6 weeks and then to a hand base, they're probably fine. But it's from that early stage of 2 weeks post-op during their dressings, and they go to the doctor, get their stitches out, and then a hand base, typically that's when you see the problem.
So thank you. That was helpful. Chris just needs to be told things 2 or 3 times to really let it sink in. So that's great.
For the benefit of the listeners, of course, right?
Of course. Can we go back to the initial nerve conversation? No, I'm just kidding. Let's definitely not do that.
No thanks.
So, all right. So let's say we're now at 6 weeks, and this patient didn't look perfect. So you immobilize her to get her to 6 weeks. She's now at 6 weeks. She's pretty happy. You like the posture. What do you focus on with your therapy between 6 and 10 or 6 and 12 weeks? Just what are the basics that you have this patient doing?
So I'll have them touch their thumb to each finger. I want to see if they're stiff. Can they oppose the base of the small finger? If they can't and they're stiff, like particularly with their MP joint or whatever it might be, I'll probably give that to them as a very informal exercise to work on composite flexion of the thumb. That's one thing. If they have full motion in that plane and they can touch their thumb to each finger, however, they collapse. They kind of, oh gosh, can you even see my thumb? Kind of like that. I'm not going to give that to them because I know that exercise is going to encourage that posture. Going back to our non-op CMC management podcast, I'm going to resume those exercises where you really try to bring your thumb out into extension, MP flexion, and make an O. And then work on making a C and work on more like extensor strengthening of the CMC joint, so that they have a stable base of support when they go open a Ziploc bag, put their earrings in, put their socks on, for example. So it kind of depends on what their exam looks like at that initial meeting. And this is for any surgery. It doesn't matter what kind of CMC procedure they had.
And
go ahead, sorry.
No, you go ahead.
Let's say that they are pain-free, swollen, and stiff. I'm going to treat it a little bit more like a fracture, like just range of motion exercises, swelling management.
Is this Dr. D's patient?
No comment. Anybody's. So I'll treat that one a little bit more to like your general fracture management, just working on range of motion, edema management, functional activities and that kind of thing. But in terms of anybody with a CMC procedure, I want to look for a few main things. One, palmar abduction. Do they have a tight web space? Do they have at least, 45, 50 degrees of abduction? Is their MCP joint hyperextending? And is their CMC joint kind of sitting in a flex position in the palm? And so those are the 3 things that I care about, and their pain. When they say, I feel so weak, or I drop things, those are all things you definitely want to listen to and respect. But I always encourage them. We can always work on strength. We can always work on things to help you function a little bit more in life. But right now we got to make sure that your thumb maintains a really healthy, solid position, whether that's with more mobilization or dynamic stability exercises that we mentioned in the other podcast.
This is really great. And unfortunately, we don't have too much more time. I love your emphasis on the control of the base of the metacarpal, because it seems like that is vital to everything. And we talked about surgical techniques to do that. And I think Chris and I certainly agree with you. If the patient is doing well posturally, and I have to throw in this little tidbit, I'm a history guy. So the test you described it's a test, going to each fingertip and then base of the small is the Kapanji. You can score it, the Kapanji score, which we use in congenital a lot. I think Kapanji was a French surgeon, and I've just looked it up. 1986, this was described, which I think is just really cool. Of course, the article's in French, so I can't really say anything more about it. But if this patient is doing well, when do you start strengthening?
When they're pain-free, whether that be at 10 weeks, 12 weeks, 14 weeks. So they've got to be pain-free for the most part, and their thumb has to be solid. So it could be 8, 10, or 12. So like on a referral that I write for you, I would often write like initiate strengthening no sooner than 10 weeks of doing well, for example, pending pain, and as long as they have not resumed a collapsed position. Like I would write that on the referral, particularly to my internal Millikan colleagues, because they know what I mean, and we all kind of agree with that management. I have to be honest, a lot of people with these procedures don't need strengthening, because if you give them putty, for example, or clips or something to strengthen their thumb, yeah, it'll make them stronger, but as they do it, it hurts. So I'm a proponent of saying, I'm not going to repetitively just strengthen you arbitrarily, because yeah, you're going to get stronger, but it's going to continue to hurt. So let functional daily activities be your strengthening. Every time you open a paperclip or a Ziploc bag or cook, you're still applying resistance through your CMC joint. You're going to naturally become stronger in time, but I don't want to necessarily just arbitrarily have you pinch something repetitively.
I think that's fantastic summary. And I think that probably as surgeons, we have an underappreciation for how long it takes to move somebody through the rehab process after the surgery, because we pretty much do the surgery and largely put it in your hands, or have an understanding that you have a protocol that you work with that maybe we talked about when we started working together. I want to ask you, as we come to a close, one question, kind of wild card question, because Chuck and I have been talking about this, and I think there's some interest in this. What are your thoughts about denervation for thumb CMC? Is that something that you think has some potential, or no? Seriously, like we're all trying to figure out what the sweet spot of helping patients through a, you said this is a painful condition, and one of our primary goals is to alleviate pain. So what are your thoughts about that?
I think conceptually it sounds really cool, given that their deficit might just be some numbness at the base of the thumb, if that's what you would expect. I have to be honest, I've only treated 2 or 3 from their first post-op visit coming from the surgeon, and they live far away, and I lose a lot of patients to distance. So you do that first initial visit where they're painful, and then I don't get to see their outcomes because they go to a therapist in their town. So I'm so sorry, but I don't have a lot to say on it, because I can't comment on the outcomes I've personally seen, but I think in theory it sounds novel and potentially excellent. I don't know. Sorry.
Yeah, I mean, creating a Charcot joint makes a lot of sense, and we should all go do it.
Touche. Good point. Good point. I think there's some room for exploration here.
Macy, I think our listeners, every time we have you on, I know they walk away just like Chris and I, grateful, because your perspective is really super helpful and makes at least me think about what we can be doing better as a surgeon. So thank you for your time.
You're very welcome. Thanks for hanging out on a Saturday at 7 a.m.
Thank you, Macy. Oh, thank you for doing that.
Oh no, this was my request, so that I could get it out of the way and go handle my young kids throughout the day. So
wow, that's exactly how I feel.
Yeah.
All right, cool.
Awesome.
Well, have a wonderful, wonderful day.
Bye.
Thank you.